A 52-year-old man with type 2 diabetes and peripheral neuropathy returns to your clinic for a 6-week follow-up. He recently received a single dose of sulfur 200C. This dashboard illustrates his progress. His nocturnal burning foot pain dropped by 60%. His sleep increased to 7 hours. Subjective vitality is surging. Then you check his labs. His HbA1c spiked to 9.2%. Monofilament testing shows protective sensation actively failing. His metabolic state is rapidly degrading. This creates an immediate dilemma. How do you proceed when the patient feels vastly better, but the underlying pathology is getting demonstrably worse? In clinical practice, we call this divergence a mixed response. It is the defining hallmark of a partial simillimum. The remedy has anchored to only a fraction of the disease totality, requiring strict methodological discipline rather than a hasty reaction. In aphorism 162 of the Organon, Hahnemann defines the partial simillimum as a medicine that corresponds accurately to a portion of the patient's symptom totality while leaving other complaints untouched. Finding a perfect homeopathic match is exceptionally rare, particularly in modern, multi-layered chronic cases. Historically, practitioners faced this problem because their physical stock of medicines was limited to whatever remedies were available in their wooden chests. Today, we have access to thousands of remedies. When we encounter an incomplete correspondence now, it usually points to a genuinely complex illness or heavily compromised diagnostic data. Managing this partial similarity requires a specific strategy. You must lower your clinical certainty, meticulously map the outcomes, and adhere to strict sequential rules to ensure patient safety. A partial match is a signal to observe the patient with greater patience. It is never an excuse for careless prescribing. When a remedy only covers part of the case, the first step is to identify where the missing data lies. The gap exists on either the patient side or the medicine side. Look at this breakdown. On the left are case side limits. These occur when the clinical history is incomplete, the symptoms lack clear modalities, or pharmaceutical suppressions are masking the true disease picture. On the right are medicine side limits. This happens when the materia medica relies on sparse proving data, weak source provenance, or poorly differentiated features. When faced with inherently incomplete data on either side, aphorisms 164 and 165 dictate exactly how to select the remedy. The text establishes a strict rule of quality. A match based on 3 highly specific, peculiar characteristic symptoms provides far more reliable guidance than a match based on 20 vague, common complaints. In a partial match, certainty comes from the profound specificity of a single clear feature, not the broad overlap of generic ailments. To prevent premature prescription changes, we have to deconstruct a mixed response variable, variable by variable. We do this using a 5-domain framework. Here is the matrix applied to our diabetic patient. Rows 1 and 2 track the target chief complaint and daily function. The patient reports a 60% reduction in burning pain, though his overall functional mobility remains unchanged. Row 3 measures general vitality and sleep. His sleep has increased to 7 hours, and his daytime energy has improved significantly. Even in partial matches, improved vitality is the most dependable sign of a positive response from the vital force. Row 4 addresses emergent new symptoms under aphorism 163. The patient recently developed a mild, dry morning cough. For now, we categorize this as a temporary accessory symptom. Row 5 tracks objective disease markers. This is where the case fractures. His HbA1c has spiked to 9.2%, and his peripheral neuropathy is advancing. This objective divergence demands immediate investigation. When questioned, the patient admits the root cause. Because the homeopathic remedy made him feel better, he secretly stopped taking his prescribed metformin 3 weeks ago. Without mapping all 5 domains, a practitioner might focus entirely on the subjective relief and falsely assume the patient was curing, entirely missing a silent, life-threatening metabolic crisis. Faced with this mixed response, a novice instinct is to immediately intervene, to prescribe a new remedy for the dry cough or the rising blood sugar. Aphorism 169 warns against this. Attempting to cover all remaining symptoms by combining or alternating multiple partially indicated remedies from the thousands available is a profound clinical error. Routine alternation confounds the vital response. It creates complex artificial medicinal diseases and entirely destroys the clarity and reproducibility of your clinical data. Instead, we follow the strict governance of Aphorism 170 for the second prescription. You cannot change remedies based on a pre-planned calendar schedule. This tracker shows the 4 required conditions for that second prescription. First, the previous remedy's action must be fully exhausted, reaching a clear plateau. Second, the case must be formally retaken, mapping only the symptoms present today, not historical records. Third, you need a documented comparative differentiation pointing to a new remedy. And fourth, you must rule out acute lifestyle confounders and medical red flags. A second prescription is never a panicked reaction to a mixed response. It is a deliberate progression dictated by the timeline of the vital force. Let's apply these 4 conditions to our diabetic patient to determine our immediate homeopathic strategy. The clinical verdict is to hold and wait. The patient's vitality and sleep are still improving, which means the initial action of the sulfur is not exhausted. Under Aphorism 163, the newly emerged dry cough is a transient accessory symptom. It does not justify derailing an actively curative constitutional response. Here we must separate classical theory from modern governance. The miasmatic framework of Aphorism 171 helps us interpret long-term constitutional patterns, but the contemporary clinical lens strictly dictates objective medical safety. The homeopathic case must remain untouched to allow the remedy to finish its work. Simultaneously, the objective medical crisis must be managed aggressively. This requires an immediate interprofessional safety net. You must firmly counsel the patient to reinstate their conventional diabetes medication today. Next, you execute an urgent escalation. A formal referral is sent to his endocrinologist to stabilize the glycemic spike independently of the homeopathic treatment. The most dangerous pitfall in chronic care is confusing subjective symptom relief with objective disease stability. They are not the same metric. Managing a partial simillimum requires the practitioner to operate with lower certainty, map data with superior precision, and maintain unyielding clinical patience.